Hello, I'm going to be presenting my HMP here on my patient. So I have a John Doe, age 98, male. Chief complaint, altered mental status, history of present illness. This is Mr. M, who is a 98-year-old right-handed Caucasian man. This patient is aphasic with known history of hypertension, heart disease, diabetes. He has been declining in health since the previous TIA 2 years ago, which left him with some residual left-sided weakness. According to his chart, his last known will time was 0500. According to ER documentation, that right-sided weakness, some speech problems while sitting in chair. EMS was called to the home and taken to the ER. The patient was taken to an outlying hospital first for eval, then was transferred. This was a patient transferred from Laredo. They had done an initial CT head at the facility in Laredo. CT was negative for bleed, so TPA was given and transferred for neurological evaluation. For report, like I said, the CT was unremarkable, which is why it was given, and he was within the window to be given TPA. Past medical history: hypertension, hyperlipidemia, type 2 diabetic, hypothyroid. Past surgical history: stents, cholecystectomy, inguinal hernia repair, and right hip repair. His family history of diabetes, mother and father, heart attack on father's side. Social history: wife denies any smoking, denies eating E2H use, wife admits to what he had recreational drug use while in his early 20s, but it's been over 6 years since he's had any recreational drugs. Allergies to penicillin. Ross pertinent review of symptoms was performed. Pretty much everything was negative except everything that was noted on HPI. Limited per my HPI. Physical exam: vitals were 98.0, heart rate was 65 to 75, respiratory rate 14, BP was 171 over 86, O2 97 on 3 liters. This is a 5'7" gentleman, 145 pounds. Pertinent labs: BUN 12, potassium 50, creatinine was 1.1, sodium 123, GFR of 10, CO2 27, glucose 223, iron gap slightly elevated 19, lactic acid 1.37, cow is 8.6, MAG is 2.0, myoglobin is 85, troponin time is 0.04, APTT is 28, albumin 1.9, WBC is 4.9, hemoglobin 13.1, hematocrit 33.9, with platelets of 150. Patient at this time just demonstrates some hyponatremia. Neurological status: patient appears to have slight right facial droop along with right upper extremity weakness and moves to his lower extremity to spontaneous movement. Left upper extremity is 0 out of 5, right upper extremity is 4 over 5, left lower extremity is 1 over 5. Right lower extremity is 5 out of 5. Hypophonic speech dysarthria presented. Pupils are reactive to light. No sclera icterus or pharynx is dry and clear. Neck, no. Adenopathy. Respiratory, clear anteriorly and posteriorly. I did not hear any rales, wheezing, or rhonchi during our assessment. Cardiovascularly, normal sinus with systolic murmur not present. S1, S2 were noted. Pupils palpable, bilateral, upper and lower extremities. Gastrointestinal, abdominal, soft and non-tender, no rebound, no guarding, no peritoneal sign. Extremities: he did not have any evidence of any edema in his lower extremities. Chronic venous stasis changed along with outer deviation of his feet and toes were present. So home medications: no home medications were brought with this patient at this time. Wife states she will bring home medications soon, but has not arrived during the time that we were there. Diagnostic data that we had was a CT head that showed some volume loss within the small vessel ischemia, but no acute intracranial process. So our outcome for this patient: we presume possible left mid-cerebellar arterial stroke with right-sided weakness and aphasia. So we're going to admit this patient for further eval status post-TPA. So fit within the TPA protocol window, so TPA was given within the ER, then transferred to the ICU for further eval. So of course we kept our neurology consult. We also consult primary. I'm sorry, primary consult us, which is why we were on the case. This time, from a neuro standpoint, what we ordered was Q1 neuro assessments after the Q15 window for TPA. We'll do a Q24 post-ops CT head. Do an EKG for what appears to be new onset AFib presented. Also do an echo with a bubble study. As stated, we're admitting to ICU for TPA protocol observation. Apply SCDs. At this time, we'll hold heparin due to the fact alpha pace is within the system. No peripheral IV sticks for 24 hours. Allow for permissive hypertension between 150s, 170s with hydrolysine PRN for systolics greater than 170. The permissive hypertension is pertinent for perfusion to cerebral flow. PTOT will be consulted, available post-op 24 hours TPA. Patient will remain NPO. We'll do a UA. Lipid panel will be ordered since we do not have one. We'll start a statin and a low-dose aspirin post 24 hours. At this time, those will be the orders that were given from a neurological standpoint. And that's the end of the case study, or end of the H&P for this patient.